Alright, so we're gonna do a weaning comp today. I'm just going to go ahead and present the patient to my doctor. The patient is 25 years old, a male, 5'8". He's post-op cabbage with no history of lung disease. He follows commands and his smoking history is 1 pack per day for 10 years of smoking. As of right now, his heart rate is 80, blood pressure is 110/65, respiratory rate is 20, and then his blood gas is completely normal with a pH of 738, CO2 of 42. His PaO2 is 72, which is a little low. His bicarb is 22, and his saturation is 95. He is on SIMV pressure support. His VT is 600, respiratory rate is 10, PEEP is 5, FiO2 is 50, and pressure support is 10. Now, as far as the weaning assessment would go, I would go ahead and give him a quick SBT, put him on pressure support spontaneous of 10/5, see how he does. So all we would do here is just change the mode from his SIMV current settings, put it on spontaneous, give him 5 plus his original PEEP of 5. Make sure his O2 matches. And then we would accept all. I'm just not going to do that so that we don't have the alarm blaring. And then once we do that, we'll let it go for a couple breaths. We're going to be assessing normal vital signs. We're going to be putting the pulse ox on the patient if he's not on a monitor already. We would, of course, be assessing for breath sounds. And that would be in at least 6 places. Make sure that we have bilateral chest rise. We have bilateral breath sounds. Make sure his oxygenation is good, his heart rate is stable. We would also be assessing for hemodynamic stability. He's adequately oxygenating and ventilating, and that there's no signs or symptoms of respiratory distress. Once we're done with the quick SBT, we're gonna go ahead, go back to our doctor, present the patient, and then recommend an actual weaning trial. If all of our numbers are within normal range and he's doing good, the patient or the doctor would go ahead and agree with us and give us the order to go ahead and wean. My first step at that point would be to confirm that I have an order for weaning in the chart. Once I do, I'm going to go ahead and gather all of my equipment, which would be myself, my pulse ox, my stethoscope, make sure I have all of my patient data and chart with me. I would go ahead and talk to my RN, make sure that all of these sedatives are titrated or cut off. We don't want any active amounts of vasoactive medications. We don't want any tube feeds, so make sure that's all titrated and cut off. Once I'm done with that, I would go ahead and glove up and wash my hands. So, and of course you want to do this for at least 15 seconds. Make sure you get nice and good. Okay, so once I'm ready for this, I'm gonna go ahead and enter the room. I'm gonna I would reintroduce myself to the patient. If there's any family members in there, I would also introduce myself to them. I would go ahead and explain why I'm in there, what I'm going to be doing. Ask them if they have any questions for me before I get started. All right. Hi, my name is Deanne with Respiratory. We're just gonna try a quick weaning trial. So basically just see how he breathes on his own to try to see if we can get that tube out of him. And then if they don't have any questions for me, I would go ahead. So since we did the quick SBT, he should already be on the spontaneous. But of course, if he's not, we'll go ahead and do the same thing, where we change the mode to spontaneous, make sure all of our parameters are correct. So we want to do pressure support 5, make sure his oxygenation is the same as his previous settings, make sure his PEEP is the same, and then accept all. I would also make sure that my apnea alarms are correctly set with the same rate, tidal volume, etc. as his previous settings, just in case during the SBT, if he does go apneic, we don't want him crashing. Once that's done, go ahead and put my vent alarms, make sure they're appropriate for the weaning trial, and then we can go ahead and accept all. Again, I'm not going to do that just to, avoid the blaring of the alarms. Now, once we're done with that, we're going to get a couple of tests done. The first one is the VC, or vital capacity. The second one is the NIF, or negative inspiratory force. We're going to do each test 3 times and get the best out of 3. For the vital capacity, we want it to be greater than 15 mils per kg. And then for the NIF, we want it to be more negative than -20. So like -25 or -30. And those would indicate his readiness for weaning and possibly extubation. So for the vital capacity, we're going to go ahead and then we would do RM. Okay, so vital capacity has its own button. It's labeled vital capacity. Once we're in that mode, I'm going to go ahead and let the patient know what we're doing and what I expect from him. Make sure he understands the directions, because vital capacities are very dependent on his understanding and his cooperation. So for a vital capacity, it's basically like the FVC and a PFT. So you want them to take a big breath in until they're full, and then they're going to blast that air out hard and fast. And we're going to do that 3 times. Here, his VC is actually 2 liters, which is beautiful and perfect. So that one passes our test. For the NIF, or the negative inspiratory force, that one is going to be more like sucking through a straw. Please remember to tell your patients that they will feel a resistance once that valve closes, and not to freak out when that happens. So then we'll do that by going down here, and that one also has its own button under NIF. And then once we do that, we're going to do it also 3 times, get the best out of 3. And then for him, and he got -40, which is more negative than -20, so that one also passes. At this point, we would go ahead and get some other parameters. We can do our RISB, our A/A ratio, our PF ratio. So for this one, you can go ahead and get out of here, go to his node. So if it was on spontaneous, you have to make sure you get his spontaneous rate and his spontaneous tidal volume for the RISB, or else it's not a good representation of what he's doing. So we're going to say that his spontaneous respiratory rate is 12 and his spontaneous tidal volume is 550. So if I get my, oh, hold on. I should go have my phone, but we can do it real quick on here. All right, so here. All right, so for RISB, you want to do his rate, which is 12, over his spontaneous tidal volume, which is 550, but you want to make sure that the tidal volume is in liters. So we're going to do 0.55 for a RISB of 21. Now for a RISB, we want it under 105, which he is. He's actually, that's a great RISB. So once we have all of those numbers, we're going to go ahead, reassess his hemodynamic status. Is he afebrile? What are his heart rate, his pulse, his oxygenation versus his ventilation? Now for a spontaneous breathing trial, you don't want it to be longer than 2 hours, but you don't want it to be shorter than 30 minutes. So at that point, I've kind of assessed that he's good to go on his own. I would let him and his family know that I'm going to be back in 30 minutes, just to make sure he's still doing good, assess if we even want to continue the SBT. So I would go ahead, gather up all my equipment. If I have trash, gather up the trash, and then go ahead and chart all of the things I've done in the room with him the first time. And then of course, if the doctor wants a progress report, we would give it to him. Now at that point, 30 plus minutes have passed. I'm going to go ahead and re-enter the room. Of course, I would wash my hands and glove up again. Again, for at least 15 seconds. And then I would be doing the same thing when I come in, especially if there's other family members that have not met me before. I would reintroduce myself, who I am, why I'm there, what we're doing. All right, and at this point, if we have any indications to stop the SBT, if he was hypotensive, hypertensive, if he showed signs of respiratory distress, like a very high respiratory rate, he wasn't pulling very good volumes, just a number of things, we would go ahead and stop the SBT right there, put him back on his previous settings, and then try again in 24 hours after a restful sleep in the morning, and then hope he does better that time. There are also different reasons he could fail the SBT. At that point, we would try to fix them before the next SBT was started. But all of his numbers look good. His vital capacity was great. His RISB was great. His NIF was great. So I'm going to go ahead and just do another assessment, another pulse ox if he's not on a monitor, more breath sounds in 6 places. Go ahead and make sure that his blood pressure is still normal. He's still doing good volumes. His respiratory rate is still appropriate. That he's still feeling great. If he is, we're gonna go ahead and call that a successful SBT, especially if it's been the 120 minutes and he hasn't had any problems or complications. At that point, I would go ahead and consult with the doctor, tell him how the SBT was tolerated, what our numbers were, what the vital capacity was, what the NIF was, what our RISB was, and then come to a conclusion whether or not we think that SBT was successful, and then whether or not we recommend extubation for this patient.